Good afternoon, everyone, and also happy International Women's Day, and welcome to today's roundtable sponsored by NAVBO's Diversity, Equity, and Inclusion Committee. I am Dr. Mahdi Garal Nabi, and I would like to thank you for joining today's session entitled Health Disparities in Women and Refugees. Can we improve care? We are pleased to welcome our guest moderator, Dr. Francine Welty, who is an associate professor of medicine at Harvard Medical School and a cardiologist at the Beth Israel Deacon's Medical Center. Dr. Welty is also the chair for the DEI committee for the ATVP. I would also like to welcome our panel, Dr. Haitham Karisha, Dr. Lina Karod, Dr. Muhammad Saleh, and Dr. Muhammad Kassab. So throughout the presentation, please type your question in the question box. These questions will be answered at the end of all presentations. If we run out of time and are unable to address your question, those questions will be shared with the presenters, and they will respond to you individually via email. This roundtable is being recorded and archived on the NAVBO website for future use. So welcome, Dr. Welty.
Thank you, Dr. Garal Nabi, and thanks to NAVBO for sponsoring this important panel discussion. The purpose of today's discussion is to highlight disparities in health outcomes and strategies that young investigators have been doing to improve those outcomes. Now, Paul Farmer has been considered among the greatest humanitarian of all time, and he dedicated his life to improving human health and advocating for health equity and social justice on a global scale. He died at the age of 62 on February 21st while in his beloved Rwanda teaching at the medical school he founded. His quote here is the foundation of our efforts presented today. So the idea that some lives matter less is at the root of what is wrong with the world. And we're focusing today on those whose lives have mattered less. Now, our first speaker is Dr. Mohammed Saleh. He is Chief Academic Director for Medical Training Express and a practicing family physician at Quadra Village Medical Clinic in British Columbia. And before he starts, I'm going to spend a few minutes on his actions which resulted in a transformative outcome for a disabled child in Syria. The Syrian war, I'm already showing my screen. So the Syrian, can you see my screen? The Syrian war lasted for about 10 years and about 16,000 children were killed. It was one of the worst humanitarian crises ever, and there's 12 million Syrians who are either refugees or displaced within their own country. So this shows Aleppo, Syria before, the beautiful building, and after. This shows a 4-year-old child before the war. You can see he was born without arms, and after the war, he lost parts of both legs from a landmine while fleeing from ISIS. I found this on the internet in 2017, and the next day I showed this to Dr. Saleh, and he immediately posted the case on Enable, which is an international organization that provides upper extremities prostheses at no charge. And within 24 hours, an engineer responded who actually lives in Boston, and he said, let's make an attachment for this right leg stump so he can work with his leg. Now, of course, first we had to find the child, and this is not easy. This is another great humanitarian, Nabil Antaki, native Syrian gastroenterologist for 40 years in Aleppo. He founded and runs the Catholic Blue Maris Charity and took this child in. And over 10 years, his group has treated thousands of injured people and saved lives of dozens. Now, due to sanctions against Syria, we can't send items there, but Dr. Intaki's daughter lives in Boston. So when he came to visit her, he took the attachment back in July 2017. And here you can see the child feeding himself for the first time, writing the ABCs with the attachment on his leg. I sent the child educational books to teach him English, and he sent videos reciting what he has learned. I have about 30 videos now. And I was wondering, how, though, can he write with his leg at a desk in school? Well, Dr. Intaki had a carpenter make a special desk so he could attend the special school that Dr. Intaki runs. It's a Blue Maris preschool. And here you see the child on his special desk writing with his leg. He then sent us a video saying he wants to join Harvard. Now, due to sanctions against Syria, they can't get enough heating oil. And so in the winter, the children have to wear their winter jackets in school. And here you see the child in the small stove in their school. And here you see him wearing the jacket and the hat that we sent him, writing with his leg. He's now in the 5th grade. So this rather simple idea was a transformative action for a child who thought he'd never be able to attend school or be accepted by other children. And the other children actually love him, and he's been in the top 3 in his class. So Dr. Saleh now is going to speak to us on Syrian refugees in Lebanon, a crisis within a crisis.
Thank you, Dr. Welty, for the introduction, and Nablo for inviting me to participate in this roundtable. My topic for today is Syrian refugees in Lebanon, a crisis within a crisis. Starting with disclosures, I currently serve as the Chief Academic Director for Medical Training Express. I have no other financial conflicts to disclose. Starting with Lebanon, size-wise, it's about 10,452 square kilometers. The population in Lebanon is 6.7 million. Looking here at the map, Lebanon is bounded from the north and east by Syria, from the west by the Mediterranean, and then from the south by Palestine. The Syrian refugee crisis started in March 2011, following the violent government crackdown and public demonstrations throughout Syria. The conflict quickly escalated. The country descended into a civil war that forced millions of Syrian families out of their homes. The Syrian refugee crisis is the largest refugee and displacement crisis of our time, affecting millions of people and spilling into the surrounding countries. These are countries like Turkey, Lebanon, Iraq, and Jordan. It's estimated that about 13.5 million Syrians in total are forcibly displaced. That's more than half of the country's population. Of these, 6.8 million are refugees and asylum seekers who have fled the country. Lebanon remains the country hosting the largest number of refugees per capita, with a government estimation of 1.5 million Syrian refugees, plus about 13,715 refugees from other nationalities. Looking here at the map, you could notice here the areas where the Syrian border is. You would see the highest densities of refugees. This is also where the Syrian refugee camps are located. More than 70% of Syrian refugees are living in poverty, less than $3.5 US per day, with limited access to basic services, education, or job opportunities, and few prospects of returning home. About 5% live in refugee camps. Here you can see 2 refugee camps in the Bekaa Valley in Lebanon. Living in refugee camps. The preliminary 2020 finding of the vulnerability assessment of Syrian refugees in Lebanon, conducted jointly by the World Food Program, the United Nations Refugee Agency, and the UNICEF, showed that the economic crisis and COVID-19 pandemic have pushed 89% of Syrian refugees population in Lebanon below the extreme poverty line. That is less than $1.9 US per day. Half of the Syrian refugee population in Lebanon is now food insecure. The Lebanese economic crisis. The chronic political instability and corruption, together with the economy that has collapsed over the past 18 months, a devaluing currency, and COVID-19 have crushed the Lebanese healthcare system. Lebanon's currency has lost over 90% of its value since October 2019. Financial crisis led banks to limit the number of dollars depositors could withdraw. That is less than 100 US dollars per month. And even some banks are not honoring that. Hospitals are no longer able to treat patients with Social Security or other public coverage. On August 4th, 2020, an explosion took place in Beirut's port near the Central District. This tragic event reportedly left more than 204 victims dead, more than 6,500 wounded, and displaced around 300,000 from their homes. Major hospitals were destroyed during this explosion. Lebanon is facing a critical shortage of essential drugs, including those used for treatment of critical conditions such as diabetes, cancer, and multiple sclerosis. The Lebanese government has lifted subsidies from many chronic medications. The lack of foreign currency has been making it hard for importers of medicines in Lebanon to pay foreign suppliers. Traders are abusing the remaining subsidized medication, where a huge amount of ordered medication and baby formula had been stashed away. Traders would wait for the price to rise and then sell it at a high price. Here's a picture of the patient with diabetic ulcer who was unable to afford his oral hypoglycemic medication. And when we saw him, his A1C was 13%. In 2021, I was fortunate to visit Lebanon and take with me some of really necessary medications that we give out for free. These medications were distributed to patients who were not able to afford it or could not find it locally. This includes medication for cholesterol or cholesterol-lowering medications such as statins, oral hypoglycemics, blood thinners, antihypertensive medications, and even prenatal vitamins, over-the-counter pain medication. Lebanon continues to suffer from massive immigration of healthcare professionals. The chronic political instability and corruption, together with an economy that collapsed over the past 18 months, a devaluing currency, and COVID-19 have pushed many health workers to move abroad. In September 2021, the World Health Organization reported that at least a third of medical staff having left the country in less than 2 years. Doctor salaries have fallen by as much as 90%. Some hospitals are operating at only 50% capacity. Lebanon continues also to suffer from fuel and electricity shortages. The fuel shortages brought in by the country's crippling economic crisis. Fuel importers blame the crisis on delays by the central bank in opening credit lines to fund fuels. In August 2021, the American University of Beirut Medical Center was appealing for urgent supply of fuel before forced shutdown could happen. They tweeted on their account that 40 adults, patients, and 15 children living on respirators will die immediately. 180 people suffering from renal failure will die poisoned after a few days without dialysis. In conclusion, Lebanon requires an immediate international help, not only to be able to continue to host the 1.5 million Syrian refugees, but also to support the 78% of the Lebanese people who live below the poverty line. Thank you.
Thank you, Dr. Saleh, for that presentation, and thank you for your efforts, wonderful efforts to get medications to these people in Lebanon. So our next speakers are a husband-wife team. Dr. Lena Karut is a postdoc fellow in radiology, and her husband, Dr. Mohammed Kassab, is a postdoc fellow in Massachusetts General, in cardiology at Massachusetts General Hospital. And they've been international medical advisors to the Blue Mission Medical Organization for the past 7 years. And they recently received funding for their efforts from the Hikma Health organization. And Hikma Health was not able to be here today, and I just want to say a few words about them. They're a 501c3 nonprofit organization founded and run by Harvard medical students. And their goal is to identify and tackle health inequality in growing migrant populations around the world. And there's over 80 million displaced people estimated worldwide. So the problem is that many of these clinics serving refugees use paper forms, and that's because they don't have internet and they don't have funds for the electronic health record. And also the electronic health record systems that we use here in the US cannot be used in the absence of the internet, and they're not designed for low resource settings. So the solution, Hikma Health developed their own mobile health data platform to help clinics rapidly deliver quality care to refugees without the internet. And it has the following key features: online, offline syncing. So when you're in the refugee camp, you don't have internet, you can enter your data, see the patient, and then when you get back to base where you have internet, you go online and work with that data. It's available in Arabic, English, and Spanish. It has 10-click workflows, including COVID screening. It can also track patients if they move from one refugee camp to another, and they do tend to do that rather frequently. You can use it in homeless, low-income populations, rural settings, emergency settings, humanitarian responses, war, natural disasters, epidemic response, COVID screening. They piloted this with Endless Medical Advantage, which is a medical van that serves over 10,000 refugees in the Bekaa Valley in Lebanon, and they were able to convert from their paper forms to totally being electronic now, and they also used it successfully for COVID screening. So as a result of that success, Hikma Health held a funding initiative for nonprofit clinics providing care for refugees, and they funded 8 and will be providing their data platform and funds to deploy it for over 100,000 patients in 2022, which they're calling the Year for Migrant Health. And these are the 8 clinics that they did fund, and here's Blue Mission Medical Van. And we will now hear from Dr. Karut. We'll start, and the title of their presentation is A Humanitarian Crisis in Refugees amidst many others.
Hello, everyone, and thank you, Dr. Welty, for the introduction. In my talk, I will provide a small summary on the compounded crisis that Lebanon has been experiencing over the last years. And also, I will be introducing the great work of Blue Mission Organization, a small NGO that provides services to refugees and Lebanese nationals in the south of Lebanon. Then Dr. Kassab will take over the presentation. So let's start. A humanitarian crisis and refugees amidst many others. So for the Lebanese context, Lebanon has been experiencing multiple crises over the last decades, which consisted of years of political instability, corruption, and war. It is located in a special and sensitive geopolitical location, bordering countries with continuous war and conflicts, which led millions of refugees to migrate to Lebanon. According to the UN authority responsible for Palestinian refugees, Lebanon is currently hosting 450,000 Palestinian refugees, and according to UNHCR, Lebanon is currently hosting an additional 1.5 million Syrian refugees, making Lebanon the country hosting the highest number of refugees per capita in the world. Also, we have been experiencing years of economic collapse, which became prominent in August 2019. We are facing inflation and devaluation of our Lebanese lira. An example is that in 2019, $1 was equivalent to 1,500 Lebanese lira, and now it's equivalent to 20,500 Lebanese lira. We have that this is actually changing. Like 2 weeks ago, it was 30, so it's not stable. According to the UN Lebanon crisis, we have an increase of 560% in the price of the food basic price, and also poverty has risen to almost 82% of the population. It is estimated that almost 9 out of 10 refugees and 1 out of 3 Lebanese nationals are living in poverty. These multiple insults has resulted in a major revolution that started on October 17, 2019. However, it was interrupted by the COVID-19 pandemic. The COVID-19 pandemic hit Lebanon very strongly, and some residents, they were left in a very difficult situation where they had to decide to follow lockdown recommendations and risk hunger in their family, or probably get COVID-19 and die. And we have the unfortunate event of the Beirut port explosion, which led to deaths, 218 deaths, 300,000 displacement, and almost $4.6 billion worth in damage. All of this crisis has a toll on the healthcare system in Lebanon, which currently is at the brink of collapse. This is due to the huge surge of refugees over the last decade, the economic crisis, which led to the migration of Lebanese doctors to other countries, shortage of medications, fuel and electricity shortage. As Dr. Saleh has said, we have the event that occurred at American University of Beirut, which is actually one of the best hospitals in Lebanon and in the Middle East. And also the Beirut port explosion, which led to the destruction of 3 major hospitals in Lebanon and damage to 12 other health facilities. And of course, the COVID-19 pandemic. So this is a small summary of some of the major events that we were facing over the last years. So Blue Mission Organization, I'm going to introduce you to Blue Mission Organization. It's a small community-based Lebanese independent organization located in the south of Lebanon. It provides services to refugees and Lebanese nationals. Currently, they have a project called Karama, which is an Arabic word meaning dignity. The project is made of 3 main components. The first component is the primary healthcare services, where it is made of a mobile medical unit that provides services to 25 shelters with 15,000 refugees. They provide medical consultations with a general practitioner and OBGYN. Also, they provide medications for the treatment of acute disease for beneficiaries in need. And also, we have a nurse and a midwife that provide awareness sessions on important topics related to hypertension, diabetes, obesity, women's health, and family planning. The second component is the mental health component. We have the 2 activators. They go to the shelters with a mobile medical unit, and they provide PSS activities to children and to adults. And they identified individuals with high risk of mental disorders and which need further mental assessment. They refer them to the team that are located at Blue Mission Center inside them, which is a psychiatry, a psychologist, and psychotherapist. And we have the youth empowerment and capacity building part, in which the team provides group discussion, educational activities to children once per week at the library in Saida, which was actually funded and renovated by Blue Mission. Here are a couple of pictures of the mobile medical unit and the Karama project. However, the Karama project is facing some obstacles, mainly the project funding issues. The project had to stop for 8 months in 2021 due to lack of funding, leaving more than 25 shelters without medical and mental support, medication and PPE shortage, fuel and electricity shortage, and also funding issues that led to inability to sustain the increased need of new identified shelters. Fortunately, this year we received the Year of Migrant Award from Hekma Health, so a special thanks to Hekma Health for supporting Blue Mission. We received $20,000 to support the mobile medical unit with laptops, tablets, internet, Google Cloud for data storage, software engineer for 1 year, and the Hekma Health electronic medical record. We are very excited to deploy the Hekma Health electronic medical record as it is time efficient, so this will allow our team to have more time to help patients in need. Also, it allows proper storage of data, facilitate data analysis, and facilitate follow-ups. We analyzed the data of 6,300 adults that visited our mobile medical unit over the last year. And we noticed that in terms of nationality, almost 80% of our beneficiaries were Syrian refugees, 11% were Lebanese nationals, and 10% were Palestinian refugees. We have that 80% were women, 89% were less than 60 years, 22% were smokers, and 82% did not exercise. In terms of cardiovascular risk factors, what was alarming is that almost 70% of our population were overweight or obese. We have that 46% were overweight, 21% were obese. Sorry, I can't see here. We have that 9 point something were diabetic, and I think it's 12.9 they were hypertensive. So for the next slide, this table summarizes the characteristics and cardiovascular risk factors of our population in terms of nationality. And as you can see, there is significant difference in terms of all variables when comparing nationalities. We notice disparities in cardiovascular risk factors in terms of gender and nationality after adjustment of variable. This table summarizes the binary logistic regression analysis of our data in terms of diabetes, hypertension, and obesity. And I'm going to briefly summarize the main findings of the table. When adjusting for variables, females were significantly more likely to have diabetes and be obese than males, but there was no significant difference in hypertension. Here we can see. Then, no difference in diabetes, hypertension, and obesity was noted between Syrian refugees and Lebanese nationals living in the same conditions. And we noticed that Syrian refugees and Lebanese nationals were significantly more likely to have diabetes and be obese, and less likely to have hypertension than Palestinian refugees. So this slide shows some disparities in cardiovascular risk factors in terms of gender and nationality in our population. Of course, this needs more further investigation and assessment, and hopefully in the future we're going to do this. So that's all from my end. Now Dr. Asad will take over. Thank you.
Dr. Karut, and thanks to Dr. Welty and Navo for the invitation. I would like to start my talk briefly highlighting on the impact of COVID-19 pandemic on the Syrian refugees in Lebanon. Knowing that the refugees make up approximately 30% of the population in Lebanon, and most of them live in high density camps with limited access to clean water and proper ventilation and hygiene services, make it an optimal condition for COVID to spread. According to the UNHCR, as of November 2021, outbreaks in displaced community account for 113,000 COVID cases, with a mortality rate 4 times higher than the national average rate. Due to the difficult situation refugees are facing in Lebanon due to the pandemic, we decided to implement, next slide please, Lina, to implement an survey-based cross-sectional study to assess the governmental and the United Nations agency response satisfaction of refugees and nationals residing in Lebanon and in Jordan. We employed a COVID score established previously by Lazarus et al. And comprised of 8 items, making a total score of 40 points. The higher the score is, the better satisfaction rate. In this study, we included almost 7,000 participants in both countries, in Lebanon and in Jordan. Next slide, please. To look at the main finding, and when comparing participants in Jordan versus Lebanon, as expected, we found that the nationals, participants residing in Lebanon had lowest governmental response satisfaction, which is mainly due to the crumbling government of Lebanon and the political and the economic crisis we're facing right now. When comparing the nationals with the refugees, we found that nationals had the lowest governmental COVID-19 response satisfaction rate, followed by the Palestinian refugees and the Syrian refugees in both countries. Next slide, please. Another important point I'd like to tackle in my talk is mental health of Syrian refugees during the pandemic. Syrian refugees in Lebanon are subject to a number of stressors, and although some of them showed remarkable resilience, but most of them need support in order to rebuild their lives. According to the most recent statistic, 1 in 5 of adult refugee population have mental health problems, and according to the Syrian Relief Report, only 15% of the refugees in Lebanon say mental health support is available for them. Therefore, we were able to get funds from the French government in collaboration with a French team to employ a study entitled Mental Health Disorders, Substance Abuse, Suicidal Ideation, and Immigration Choices in Vulnerable Population in Lebanon during the economic crisis and COVID-19 pandemic. Next slide, please. In this study, we implemented 2 waves over 18-month duration. In the first wave, we will conduct 40 to 60-minute in-person interview to assess mental health disorders, suicidal ideation, substance abuse, immigration changes, and also we want to conduct COVID-19 survey. In the second wave, and we will do follow-up after 1 year, and we'll reassess participants. We're also trying to secure additional funds to add a new cardiac component to the study, in which we will ask participants to self-report cardiovascular risk factors, past medical history. We will measure their blood pressure, height, weight circumference, and BMI. And we are also trying to provide the mobile medical units with Jana Care devices, which will allow us to provide instant lipid and HbA1c and creatinine readings, which eventually will allow us to calculate the 10-year risk with the pool cohort equation. Next slide, please. I would like to end my presentation with 2 cases of Syrian families, Syrian refugees family, which we are trying to help. Lina, next slide, please. We're trying to help. First, we want to start with the family of 8 members living in 2 rooms, as you can see, where they have 2 daughters, where they have 2 daughters with severe retinitis pigmentosa. Dina, can you go back to the slide? Yeah, which resulted in almost complete vision loss. However, we know that they suffered from irreversible blindness, but we were able to find a drug that could potentially help. However, it has a sticker price of $1 million, which make it prohibited and impossible to consider by the family. What's really sad about these girls is that they never received any financial support from the UNHCR or any other organization, and they have never attended schools as they could not afford the cost of schooling for children with special needs in Lebanon. Next slide, please. Next slide. The second case is the case of Syrian refugee family with possible blepharophimosis ptosis epicanthus inversus syndrome. This syndrome is a congenital complex malformation characterized by narrowing of the eyelids opening and dropping of the upper eyelid ptosis, which may increase the risk of causing amblyopia, which may cause blindness if left untreated. Also, BPES type 2 is associated with primary ovarian insufficiency, high risk of primary ovarian insufficiency. This family differs from the other family we showed previously, because it's still irreversible. The condition is still irreversible, and we should act now in order to prevent further deterioration of the vision of these kids. Till date, the family could not afford the price of the molecular genetic testings and the surgery, which in total cost around $14,000. Thank you very much. That's it.
And thank you very much, Dr. Karut and Dr. Kassab, for the hard work that you've been doing for these refugees in South Lebanon.
Thank you for all your guidance also.
Oh, it's my pleasure. So now we'll go to the final speaker, which is Dr. Haitham Krayshaw. He's a cardiology fellow at the University of Maryland, and he's going to speak to us on another group of people whose lives have mattered less. That's women. And the title of his talk is Worst Cardiovascular Outcomes in Women, Potential Solutions. Dr. Krayshaw, we look forward to your talk.
Thank you, Dr. Wolty and Dr. Garo-Nevi for the invitation and the kind introduction. I have no financial conflict of interest, and the goals of my talk are to identify 6 disparities in the presentation, risk factor profile, pathophysiology in acute coronary syndrome, and recognize 6 differences in the management and outcomes of ACS. And also we need to recognize the regional differences of sex disparity, and finally identify potential solutions and mend the knowledge gaps. So I want to start my presentation with a case. This is a real-life case that we encountered recently. We have a 42-year-old Spanish-speaking female with no significant past medical history who presents to the emergency department with an epigastric pain. The pain is associated with shortness of breath, and it is non-specific when it comes to it. But she mentions that it is worse after eating a heavy meal and sometimes with walking. Her vitals were stable overall, but her blood pressure was a bit elevated. She's obese. Her CBC showed a little bit of low hemoglobin, and AST/ALT a bit elevated. Troponins were negative, and we did an abdominal ultrasound, which showed no evidence of cholecystitis. As when she came to the emergency department and she had that abdominal pain, she had T-wave inversion in the inferior leads, as we can see from this EKG. This EKG is not the patient's; it is taken from the internet. So I will stop here. The patient was discharged. I will stop here and we will come back to our case in a few minutes. But I want to talk about the motivation for this talk. Despite the huge public health success story in prevention of premature cardiovascular death from the 1950s by winning the battle against tobacco smoking, angioplasty, stents, aggressive blood pressure control, aggressive lipid control, and the introduction of anti-hyperglycemic medications, cardiovascular disease remains the lead cause of death worldwide, and it cultivates the lives of more than 8.6 million women. Every year there is, or currently there is 275.5 million cases of CVD in women worldwide, and the highest burden is in low to middle income countries. There is, as I said, 8.9 million cases of cardiovascular death in 2019, and 35% of all women death is attributed to cardiovascular disease. And the greatest burden, and women has the greatest risk factors of cardiovascular disease, diabetes, hypertension. We will talk more about atypical symptoms. They often present later to the hospital, and they are less likely to receive guideline-directed medical therapy. So let's talk a little bit about disparity in presentation. Overall, women present like men with chest pain. This is the majority of women. However, women are less like or are more likely to present with atypical symptoms. And when we talk about atypical symptoms, we mean shortness of breath, pain in the interscapular region, abdominal discomfort, nausea, and the rates of those atypical presentations is much higher than men and in men than women. In one study, they found that almost 37% of women presented with atypical symptoms, while only 20% of men presented with typical symptoms. So the other aspect of it is the pathophysiological considerations. Women tend to have different pathophysiology of coronary artery disease. This prospective trial was very revealing in the fact that women had more plaque erosion rather than plaque rupture. With plaque erosion, we have multiple factors, including connective tissue disease factors that might kind of contribute to the erosion rather than rupture. The composition of plaques are different between men and women. Women tend to have more necrotic material than men have more cholesterol deposits. We have also microvascular dysfunction and coronary vasospasm. The other aspect of it, women are more likely to have a spontaneous coronary artery dissection, or what we call SCAD, and it is usually associated with younger women who are pregnant or on oral contraceptives and or who have connective tissue disease like SLE. And finally, women are more likely to suffer from stress-related Takotsubo cardiomyopathy, which in general has a good prognosis, but that is most likely that is related to hyperactive sympathetic activation. So let's talk about women presenting with ACS. We talked about their atypical presentation, but across the universe, whether it is in a high-income country or in a low-income country, women are more likely to present later. They are, once they present to the hospital, they are more likely to, or they are less likely to be diagnosed as fast as men. And then once they are diagnosed, they are less likely to receive pharmacological therapy, and they are less likely to be discharged from the hospital with appropriate pharmacological therapy, and that they are less likely to receive invasive treatment like PCI and angiography. However, here comes the separation between the high-income countries and the low-income countries. And actually, this photo was taken from Baltimore, from one of the streets. The left is an area which basically is high income and is well maintained. And what we found that women in high-income countries, despite all the disparities, they still have similar long-term outcomes. And in hospital outcomes differ, but older women tend to have similar outcomes like men, but younger females have potentially worse outcomes. But the results of different studies are controversial. While in low to middle income countries, women definitely have worse in hospital and worse long-term outcomes. And when we talk about outcomes, we mean death, heart failure, re-infarction, and peripheral vascular disease. So I want to highlight our study that we conducted an analysis of the ACS-QUIK trial database, which is from Kerala, India. The trial included 23,000 subjects with ACS. 5,000, almost 25%, were females, and 12% of the total population were young, meaning that they were, or were young females, meaning that they were less than the age of 50. What we found that in the total group, women were more likely to be older, they have more risk factors, they were more diabetic, and notice the difference, 53 versus 41, that's almost 10% difference. They were less likely to be smokers, and they were more likely to have hypertension. On the flip side of the coin, women presented later to the hospital, almost 300 minutes versus 230 minutes. That is almost an hour and 15 minutes later than men. And they were less likely to receive PCI or any sort of invasive treatment. And that's very alarming. What we found for the total group, comparing all women to all men, we found that women had higher in hospital MACE or major adverse cardiac outcomes, and they had 53% chance or 53% higher chance of getting MACE. And also at 30 days, which is an intermediate outcome, they had almost 40% chance of getting adverse events. While in a subgroup analysis, where we compared younger women to younger men, we found that in-house or in hospital, women were 60% more likely to have bad outcomes compared to men. However, there was no significant difference at 30 days, although we found some trend to harm. And we believe that our data or sample size in young women were small to detect significance. So let me take the case back to the bedside. This patient, who's 42-year-old, she's Spanish speaking, and she presents with non-specific symptoms. Her symptoms were mainly abdominal, maybe related to some sort of exercise. She presented 2 weeks later to the hospital with severe abdominal pain, nausea, interscapular pain. An EKG in the emergency department was done, and it showed this. And this is very alarming. He came with ST segment elevation MI, which is the worst form of myocardial infarction. And she underwent PCI, and we found an RCA lesion. However, I just want to take it back a little bit. We were setting her to failure. She's Spanish speaking, she's a female, she's in a reproductive age group, and she has shortness of breath, non-specific symptoms. So as we go through pattern recognition that we learned in medical school, we most probably ruled her out for heart disease. On further questioning of the patient with a interpreter, we discovered that her dad actually had a massive heart attack at the age of 38, and she was diagnosed with familial hypercholesterolemia. So That takes me to potential solutions. How can we deal with that? And before I talk about potential solutions, I love to quote this study by Mr. Jian et al. And in this study, they presented professionals, doctors mainly, with videotaped vignettes of ACS. Middle-aged females were more likely to receive a diagnosis of mental health condition, although it was geared towards ACS. And this takes me that the solution of the problem is not to direct it towards the victims, which are women. It's actually ourselves, the medical community. We have implicit biases, and the way we think about cardiovascular disease, luckily now it is changing. Historically, it's a man's disease, and we should think about it and rethink about it in different terms. And here I want to shed the light on the differences between sex and gender. Sex is a biological concept. It is shared with animals. It is related to your chromosomes. While gender, it is a cultural and social construct. And the gender role in different regions of the world are different. And that's, I believe, why in low to middle income countries, women are more likely to experience harmful outcomes of delayed presentation and delayed care of ACS. And as we tailor our therapies and that we educate medical professionals and as we educate women, we need to take the social and cultural context into consideration. So what can we do to improve women's health and cardiovascular disease? First of all, we need to remove barriers to healthcare. We can do more of televisits. Maybe this is one of the silver linings of the pandemic, that we can reach out to we can do more outreach to women in distant or rural areas. We can educate women, raise awareness of atypical presentations of ACS. We can empower them to take health-related decisions in areas they might not kind of have those powers. We should, in some of the Middle Eastern countries or even in sub-Saharan Africa, we need governmental policies for equitable access to healthcare. We need to include more women in RCT. Historically, women were excluded from randomized controlled trials, and we need to make sure to include more women to understand the benefit of different treatments in women, B, the potential side effects. And we should encourage investigators to conduct disparity studies worldwide. We also need to bend the gap on the pathophysiology and sex-related disparities in different regions across the world. And finally, we need to lead by example, and we need more women in cardiology so that they can educate women and serve as role models. And talking about International Women's Day and Women in Cardiology, I would love to thank Dr. Francine Wolty. I just want to take 2 minutes. I met Dr. Wolty 5 years ago as she took me in as a postdoctoral fellowship, bridging to residency. And she has been a super mentor and kind of the one who's propelling my career forward. So I want to thank her on behalf of my colleagues and myself. And thank you so much for the opportunity. Have a good day.
Well, thank you, Dr. Crayshaw, for that excellent, comprehensive overview, and thank you for the efforts you're doing for the study in India, and also thank you for acknowledging me. I appreciate that. I should also comment that Dr. Crayshaw brought back a new suitcase full of new clothes for that child in Aleppo, Syria that I showed you earlier. The clothes were beautiful, and Dr. Intaki took the suitcase back to Aleppo, Syria, and the child was known as the best dressed little boy in Aleppo. So thank you, Haitham, again for doing that. All right, well, I want to thank all the speakers and thank everyone, all the attendees who have joined. And I think I'll turn it over now back to Dr. Garal-Nabi, who's going to direct some questions to our panel.
Thank you, Dr. Wolty, and thank you to all the speakers. I think this is very timely, and I wouldn't have thought of any other presentation on the International Women's Day, and also with the international political climate that we currently live in. We stand with all those refugees, and we stand with all those being, affected by wars all over the place. Our hearts also goes out to those Ukrainian, refugees and women and children who are currently crossing the, the borders of their country, into a safer place. We pray for them. Hopefully, everybody get safely out there, and we also pray that this current Russian, war to be stopped as soon as possible. I'm just speaking out of my script, but I speak my heart that goes out there for those, refugees everywhere. Refugees are refugees if they are in Ukraine or in Syria or Lebanon or all other parts of the world. So most of the cases, usually those people are, fleeing their countries for, for no fault of them. So thank you very much. I don't see any questions in the chat. In the meanwhile, please do, do write your questions on the chat, and I'll get them out there, read them out to the panelists. I would like actually to start in the meanwhile until we get some questions on the chat, on the questions rather. I would like to start with Dr. Saleh, who started earlier. Thank you so much for shedding light on the Lebanese crisis. It's really a huge crisis, and it's really unspoken because it's not really receiving enough attention, and due to other burning issues around the globe. So Dr. Saleh, can you please shed light a little bit on the status of the Syrian refugees in Lebanon? I wonder if they also get access to the medical, the government medical facilities that the Lebanese also receive. And if since this, refugees, they really, especially in Aleppo and other places, we already know that there were some chemical attacks on those people before they fleeing. Some of them already died because of the chemical attacks. So they may require some special type of attention and treatment. So I wonder if any facilities in Lebanon is capable enough of treating those chemical exposure that some of those refugees went through, and whether or not also the Lebanese hospitals treat all refugees, Palestinians, Syrians, and equally when they come to their facilities, or do they face some sort of priorities, like the priority for the Lebanese first, who are already suffering? So I'll leave it at there, and I'll come back and ask other questions to the other panelists.
Sure. Thank you, Dr. Galnavi, for having me. And this is a very good question. The truth is, right now, the medical kind of assistance, those Syrian refugees that they're receiving, whether it is from the NGOs or local hospitals, is very limited. So one, they do not have access to local hospitals without having, previous sponsors or special permission. That someone who's going to guarantee that their bill is going to be paid. And that sometimes can be done through the NGOs, sometimes can be done, through private sponsors. Now, in terms of the type of, treatment that they're receiving, this also can be very limited. I know there's a lot of NGOs out there that are trying to help, trying to arrange for private surgeries, whether if it is not available locally, sometimes they transfer them or fly them to surrounding areas such as Jordan, and then they could receive those medical procedures. In terms of the current situation has been changing a lot. So the whole Lebanese healthcare system is now collapsing and suffering. And now the treatment, it's not only to Syrian refugees, even Lebanese themselves are having a hard time getting to go to hospitals and getting the procedures that they need, or the medical treatment that they need. And that's due to all the issues that we discussed, whether it is the fuel shortages, whether it is hospitals refusing to accept Social Security or other public coverage. And that's been making it hard for people over there.
All right, thank you very much. I think these are, great point. If you could also shed light a little bit on the condition of those refugees coming from Syria, particularly after chemical exposure, and whether or not there are some capabilities out there, provided by the WHO or any other international body to help actually alleviate those sufferings.
I mean, truthfully, I don't have information on the chemical exposure, the conditions that they might be suffering from. I'm not sure if my colleagues here, Dr. Karut and Dr. Kassab, have some cases about people who specifically had previous chemical exposures or other biological weapons that might have been used. But yeah, I don't have specific details on that one.
All right, it looks like we may have a question here. Let's see. I don't really see that question. Oh, I don't see it at my end. It's not appearing in my question site.
Hi, Mahdi. I can ask the question.
Yes.
It's from Dr. Zhang.
Yep.
May I ask, what do you think the progression for the healthcare of women and refugees is over the next few decades? And I think if any panelists would like to respond to that.
So Lena, Mohammed, Kassab, do you have any comments on your work and with the refugees in South Lebanon? Do you want to turn on your webcams?
Yes, I have no major comments regarding women's health. Unfortunately, UNHCR and even NGOs in Lebanon are not mainly focusing on women because the basic services to refugees, which is primary healthcare services, is not being provided to all refugees. So, but according to our data, we have noticed that there's much need to focus on women, especially since we noticed that there's significant difference in the incidence of diabetes and obesity in women compared to men, which is a major risk factor for cardiovascular disorders. And most importantly, we have to focus on obesity since it's a preventable cardiovascular risk factors that can be actually prevented, and interventions that are very effective. But unfortunately, to my knowledge, there's no program right now. I don't see anything within UNHCR or any NGO focusing on this. Especially we at the mission, we would love actually to add a cardiovascular component focusing on chronic diseases, but we are not even having funds to maintain the main project right now. So we have funding issues. So hopefully in the future, depending on the economic situation and funds in the future. Thank you.
Dr. Carl, since you're here, can you comment a little bit on whether or not there are any, actually, what is the role of the, Lebanese and Syrian abroad organizations in terms of, helping with the refugees in Lebanon? Are there any collaborative efforts between those organizations? Is there an umbrella that actually help with all these processes?
Yes, so in Lebanon, regarding the healthcare services to refugees, UNHCR is the main responsible authority, but of course they act in coordination with international and local NGOs. We usually, when I used to work at the mission, we used to go to UNHCR once per week, and we used to meet and explain our difficulties and our needs. And at the same time, they used to provide us with new information regarding hospitals and primary healthcare centers with their new services for free for refugees. Right now, to my knowledge, there's a list of hospitals and primary healthcare services that refugees can attend and go free of charge. And also, there's a collaboration between UNHCR and the Lebanese government in which they provide even chronic medications for hypertension, diabetes, hyperdyslipidemia for free or with a very minimal cost. But as we know, this services is only for Syrian refugees registered at UNHCR. We have also a great portion of refugees which are living in Lebanon illegally and they are not registered. So this specific group of refugees, they mainly they will go to NGOs for some services, but of course it's not enough.
And why are they not registered?
Because I believe that they have no sponsor. I'm not sure about why, but I think they can't be registered for some reason. And there's a great portion of this. And even the Palestinian refugees, we have, like, for example, 450,000 Palestinian refugees, but it's estimated that only 320,000 are registered. There's the other group, they are not registered. But I'm gonna check why exactly they can't be registered and circle back to you. Thank you.
So we are almost 4 minutes on top of the hour. So Dr. Welty, if you want to take it from here.
Sure. And Mahdi, maybe I'll just make one more comment about in Aleppo, Syria, just so people, the audience and the attendees know that they have a great need. And you could see that Dr. Antaki and the Catholic Blue Maris charity group have done really phenomenal things. But there are sanctions against Syria, so we can't even send things there. For example, they asked me to get coronary stents donated, and I found 2 companies that would do the donations, but then they found they can't send them there because of the sanctions that are against Syria. And we're actually working, we had over 5,000 people sign a petition and send a letter to Joe Biden, the president, to relieve these sanctions. And then a second letter was sent with emphasis on the humanitarian aspect. Could you at least relieve some of these so that medical supplies could have a better chance of getting in? So it's a very frustrating situation and we need help. Anyway, I want to thank everyone for attending. I want to thank the speakers. Your presentations were all outstanding. And thanks again to Dr. Garanabi and NAVO for sponsoring this very important panel discussion.
Thank you. Thank you, everyone.